So when should we match? We may match in a cohort or a case control study to increase precision, and we may match in a cohort study to reduce confounding. However, disadvantages are also balanced by many disadvantages. For example, matching will be more costly because you're going to spend a lot of time and resources trying to match, and especially when you're matching very finely. You may also reduce precision because you try to find a matched participant and you may not be able to, and so you actually may not be able to recruit the participant, and you may end up losing power. But also you may see that there is a precision loss, and you will see that. Also, you're going to introduce selection bias. Like we've seen that if you're overmatching, you're going to make the cases and controls more similar. So that is selection bias. You also need a special analysis. So for example, if you're doing multiple studies and you're trying to combine them and some are matches and some are not, you have quite a lot of difficulty. Also, once you match on something, you will never be able to estimate the effect of that factor anymore. And so you might never finish your study. It can become quite intensive. So be very careful when you decide to match, and then ask yourself, is it really needed? So when do you match? In cohort studies, you might see that occasionally done. And this really does help in controlling for confounding. However, if you match in a cohort study and then you have a lot of attrition where you lose people and participants as you're conducting your study, then the advantage of matching will disappear. In case control studies, matching is done way too often. Matching does not control for confounding, and we will see an exercise to show that numerically. So you're really only matching in a case control study if you're anticipating very small number, like 0 cells, for example, for major imbalances between cases and controls. So for example, if you're looking at cancer cases and then you don't match them to controls, you might end up with cancer cases to be very old and controls to be very, very young. And so you're going to have a difficulty putting the data together and analyzing it. Although matching would not be the only possibility, I mean, you could do restriction if you wanted to. And you want to match on a factor that is a well-known confounder strongly associated with the disease. And so you can use directed acyclic graphs to show that. Now, in cross-sectional studies, you cannot do that because you do not know the exposure and the outcome. You take a slice of the population or of a group, and you don't know upfront whether these are exposed or not, or have the disease or not. So matching in a case control study increases bias because you're actually now introducing selection bias that you didn't have before, and you don't reduce confounding. Because you're matching cases and controls, selection bias is typically toward the no. And the cases and controls will become more similar with respect to the exposure. So can you randomize match subjects, and how? Or can you match randomized subjects, and how? So in a clinical trial, you can randomize match subjects. For example, you can randomize a pair of subjects so that one person in the pair gets the placebo and the other person gets the drug. You can also match randomized subjects. For example, you can have a patient come back. The first time he receives the placebo or the drug, and the second time he receives the drug or the placebo. So the subjects are randomized to sequence rather than to treatment, for example, in a crossover study. So matching can be done in a randomized control trial, and this often improves precision. It reduces potential imbalances across treatment groups. So you might see the term blocking. And again, you want to do it sparingly. If you want to block, you block only on very selective factors. They should be worrisome confounders that are strong risk factors for the disease.